Well, hello. I'm back in my little lair, as you can see, rather than last week when I was somewhere else. Welcome to the Maternity and Midwifery Hour. My name's Sue Macdoanld. I'm the curator for the Maternity and Midwifery Hour and the Maternity and Midwifery Festivals, and it's my pleasure to be chairing the session this evening. And I'm delighted to be welcomed by be welcoming Dede Thorpe to this evening's session. So welcome, Dede. Now, we always have to ask our guests to share a moment of the week, and Dede's got a really special moment. So welcome.
Hi, thank you so much for having me. It's a pleasure to be here. And so I think what I would like to share, my moment of the week, was a very special moment I had today, actually, this morning. So as I'm sure you can see, I'm a preterm specialist midwife. I work in Hertfordshire, and I have the privilege of being kind of with part of that multidisciplinary preterm birth team. And today I got the opportunity to share some of our services and showcase our preterm birth service to our trust board. So that's all of our sort of very high level people, chief execs, chief people person, lots of titles I didn't know before, chief Kaizen officer, on non-execs as well. Anyway, there were lots of very, very important people there. And I got to tell them a little bit about what we do in our preterm birth service, share one of our patient stories, which is actually one of the ones I'll be sharing tonight as well with you guys. So a very wonderful opportunity to show some of the things that we're up to in preterm birth and what we plan to be doing over the next year or two. So that was a very special moment for me.
Fabulous. That is, and you know what floats through my mind as you were talking? I was thinking, I wonder when you were a student midwife, if you ever imagined doing that to such a group of people. And I love the way you say you didn't even know some of the sort of titles existed, because that is absolutely sums it up, doesn't it? Can you imagine as a student midwife being in that situation and being confident? It's wonderful.
Thank
Oh,
you
we've
for
lost your
talking
voice.
about my specialty. Yeah, can you hear me?
Yes.
Oh yeah, so I said as soon as I get talking about my specialty, all my nerves sort of fade away because that is what
Oh,
I do, my bread and butter.
wow. Oh, thank you so much, Dede. Now we're going to let Dede have a little break before she starts speaking. And I'm just going to welcome all of you who are here this evening. I know some of you are old friends, and I know some of you might be new to the Maternity Midwifery Hour. And I kind of need to celebrate the fact we are now in Series 19. This is session 11 of Series 19, and we started 6 years ago when the first COVID-19 lockdown started. And really, this was a way to make sure we could connect with midwives, student midwives. Actually, we had paediatricians, we had obstetricians, we had maternity care support workers, all sorts of people joined us. It was a way of being able to connect and find out information about, especially COVID, and what was happening in the maternity services to deal with it and manage it. Because as you remember, if you were in the service then, a lot of things had to change. We had to move things online. Students had to change the way they were learning because we had to keep them safe whilst making sure they were getting the experience they needed to become midwives. A lot of exciting things went on. And we're not doing so much on the COVID now. We're doing things that are of importance to midwives and student midwives at the moment. But and people seem to still like coming along every Wednesday, which is fantastic. Everything is recorded, and I need to say this, and I'll probably repeat it about a million times. We record everything because we just do, because it's all valuable and we like to be able to share the information. So you'll get a link to this on the newsletter tomorrow, and also there's a podcast on the same thing on 6 o'clock in the morning on Friday morning as well. And those you can share. We're very happy for you to share. We're not secretive about it because we need you to share, because we think that's the best way you can learn. And it's by talking and sort of thinking, because you're going to learn new things this evening, things that you might want to take into your practice or your service, or you might want to share with colleagues. So we're very happy for you to do that. Now, this is all looked after by Matflix. And there's a link on the resources sheet that Paul is sharing on the Facebook bit of the web. And you can access that as well. Now, if your university as a student, or if your maternity unit has a subscription, then it's easy to get into Netflix. If you want to get a subscription, it's a price of a couple of cups of coffee, I think, every month. It's not very expensive. But I'm going to give you a health warning. It's a bit addictive once you get into there. If you're doing something like a dissertation or a project or an assignment for your studies, really good resources. You just tap in to search, you can find all sorts of information. And if you're doing your revalidation, you can also do some of the kind of reflective activities with it, and that really helps record things. So I can recommend that to you. But it is addictive, and you can find that a couple of hours have wafted by and you've learned a lot, but a couple of hours have wafted by. And I also want to say a big shout out to student midwives and midwives I met in Bradford last week, really, at the festival, which was fabulous. Really enjoyed that. And if you're wanting to come to the next festival, that's in Cardiff in September. So keep an eye out for booking for that. And also, I want to just point out at the moment, things are hard in midwifery at the moment and maternity services, and you need to look after yourselves. You need to look after your colleagues, your students, and yourselves, because that's really important. Now, I've got just little bits of news today. There's one thing I heard, that the National Bereavement Care Pathways for Pregnancy and Baby Loss have been launched in Wales this week, which is really good standard of care for people to be using. Also, it's Group B Strep Awareness Week, 8th to the 14th of July, and the Group B Strep Support Charity. It's a great source of information if you haven't accessed it. Again, that's on the resources sheet, and this has got a free, we like free things, CPD accredited Group B Strep e-learning module covering prevention, identification and treatment of Group B Strep. So if you're a bit rusty on that, really good resource to access. Again, the link is on the resources. And I know Dede was talking about her moments of the week. One of my moments of the week was just catching a little moment on Sheena Byram's little podcast, and she was talking about this lovely little book, which I do happen to have, The Roar Behind the Silence, and many of you will have this book. It was published a little while ago. Fantastic editors, i.e. Sheena Byram and Sue Down, with a fantastic array of authors writing some really interesting material, which is very, very relevant to today's midwifery and maternity services. And it kind of, the way Sheena was talking, I thought, yep, I need to return to this. So I've got this out and I'm going to have a little reread of it. And I would suggest, if you have it, get rereading. If you haven't got it, you need to get this book. It's very useful. Also, that's on the list of resources too. You might find you can get a cheap edition, but it's pretty good price anyway. Okay, now, see, I've spoken so quickly and perfectly. We're almost on target here. Now we're going to be looking at improving the service and most importantly, improving outcomes for mums and babies with prematurity, i.e. birth before 37 weeks of pregnancy. And we are joined this week by Dede Thorpe, who's a preterm specialist midwife at East and North Hertfordshire Teaching NHS Trust. She has a decade of experience supporting women through pregnancy, birth, and the postnatal period across both NHS and private settings. And her clinical practice has been shaped by a deep commitment to continuity of care. And that's such an important part of our practice that we need to focus on. She saw firsthand the transformative impact of women feeling heard, informed and supported throughout their maternity journey. Alongside her clinical work, she's the author of Navigating Prematurity, Stories, Strength and Self-Advocacy, a resource designed to empower women with the knowledge, confidence and language to advocate for themselves within maternity care. And this book actually aligns with national priorities, including the NHS long-term plan and Saving Babies' Lives Care Bundle, by supporting early recognition of complications, improving engagement with services and strengthening shared decision-making between women and healthcare professionals. Now, there is more of Dede's CV online, so do check that out as well. But in the meantime, I'm going to say a huge welcome to Dede. The screen is now yours, and thank you so much for coming this evening to share your expertise with us. Wonderful.
My pleasure. Thank you so much. I love talking about prematurity. I want to see a difference in our outcomes and in the impact that we're having with prematurity. So that is what I do day in, day out, in my contracted hours and in my spare time, which I don't have very much, but we make it work. So yeah, so what I do as a preterm birth specialist midwife, which I've been doing that for sort of about 4 years now. 4 years in May. I've been supporting lots and lots of families through their journeys in new pregnancies, usually where they've had a previous history of either preterm birth or they're coming into this pregnancy with risk factors that can increase their chances of preterm birth. And these are just some of the families that I've been able to support. And I've put also there like a picture of one of our obstetricians who's amazing, Dr. Rachel Waldridge. Give a big shout out because she, without her, I wouldn't be here. She has trained me very well to kind of be where I am. I've been to different conferences as well. Every year we have preterm birth conference where we're learning about what's the latest innovation, what is the new evidence coming out, and how can we embed that into our clinical practice, what research is out there. So I've been doing a lot of work, also developing my own sort of research style and proposals that we can take to try and improve services for women and outcomes for babies and their families. So this is what I do. I also in my service will support women with referral. When they're referred into our service, I will manage that, make sure they get seen at the right time, at the right gestation in a preterm clinic. And we offer holistic care. So it's not just the preterm care. It's also, ensuring that other aspects of their holistic well-being are seen to. That might mean perinatal mental health. It might mean linking with other specialists, such as diabetic specialists, smoking cessation as well. So lots and lots of holistic care, as well as lots of TLC for some of these families who may have experienced loss or a traumatic previous birth as well. That's a bit about me. Why are we talking about preterm birth? What is the current state of maternity at the moment? I think, as Sue's mentioned, we know where we are. We've had reports recently to tell us the struggles that our profession is facing. Maternity services are facing unprecedented pressure. We're stretched with staffing. We're not able to provide continuity of care, even though we know it's the best model of care for women and families. Women feel rushed through appointments. They feel unheard. They feel dismissed during appointments. Birth is very complex now. There's, very low number of sort of low risk women. We don't know where they are. But now it's more complex. Families are anxious. There's a lot of uncertainty. And actually self-advocacy is becoming increasingly essential for safe and personalised care. And prematurity is a significant public health issue. Actually, up to 8% of babies every year are born prematurely. Many women who have a preterm birth don't actually have identifiable risk factors for preterm birth. And this is where the challenge lies with prematurity. It remains a leading cause of neonatal morbidity and lifelong disability as well. And families then are, left with trauma. There's fear and uncertainty, and there's a lack of understanding about their risk or lack of understanding about what has happened in that process that's led to preterm birth. And that, just to give a little bit of an idea of the cost of prematurity in the UK, £3.4 billion is spent on preterm birth every year. And the cost to care for a baby in the neonatal unit ranges from £27,000 to £95,000. So the earlier your baby is born, the more it costs to support and provide that life-sustaining, life-maintaining care for those babies. So baby born at 31 weeks, it would cost about £27,000 to support in hospital to provide the best care. And then you've got up to, if the baby is even more premature at 27 weeks, that's £75,500 to sustain, and to provide the best care for that baby. And now actually babies are being born even earlier than that. And, at the cusp of viability, we have these babies who some are being born from 22 to 24 weeks and are surviving. And so just imagine the impact there. But beyond the financial impact for the NHS, we look at the cost health impacts for these families families and these babies. Neonatal death, that's significant, and it's more likely if the baby is very premature. We've got illness and lifelong morbidities that are associated with prematurity. They have lung problems if they're born too early and they need lots of ventilation. There will be issues with the way their gut works, so they're more likely to have gut inflammation and death of parts of their gut, called necrotizing enterocolitis. They're more susceptible to brain bleeds because they're just so fragile, and these can mean that actually they end up with neurodiversity, neurological problems, and complications such as cerebral palsy, for example, and eye disease. Those are way more common in premature babies. And then that's not even talking about the cost to the poor families who are dealing with transport, just getting in and out of neonatal unit to see their precious little ones. The cost of transport, the cost of parking. I don't know about you guys, but the cost of parking in my hospital is quite significant, even for staff. So we do have passes for our neonatal families, so that's great opportunity to get sort of free parking. But they've also got relatives who want to come and visit the babies. There's different times of days they want to come. Sometimes women can't drive if they've had a cesarean section, so cost of taxis, things like that are all things that we don't really factor in or don't think about. And the cost of childcare if they've got older children and they're still trying to sort of maintain that balance in the household, loss of income. There's so much that it costs when you have a preterm birth that goes beyond finances, but also significant finances as well. So that being said, what are we going to do about it? How do we identify this? What do we know that leads to preterm birth? So preterm birth is multifactorial, and that is part of the challenge that we have with trying to narrow down, pinpoint, and sort of eradicate, as it were, preterm birth. It can be caused by different types of infections that sort of increase that risk for mum and baby. Significant infection can set up inflammatory processes in the body that then can trigger that labor process as well. So think if you've got a raging urinary tract infection, for example, that leads to the kidneys, your body's fighting so hard to recover and fight that infection, and it sends out lots of inflammatory agents to try and combat that infection, and some of those will be involved with setting up a higher chance of preterm labour and birth. Previous preterm labour and birth, that's usually associated with potentially a weakened cervix. So what some people might know as cervical incompetence or cervical insufficiency, which I think is a much kinder term. Where there's an inherent weakness in the cervix, that can be associated with mums coming in because they feel there's just a pressure and they're changing their discharge. And actually, you do a speculum examination, you see that they're starting to dilate, and that is quite common with that kind of weakened cervix. We've got cervical surgeries where a part of the cervix has been cut away because of abnormal cells or for treatment of cancer. So actually their cervix is artificially shorter, which means it's not able to function in the same way for some women. So many different reasons that women can end up with a higher risk for preterm birth. And one of the ones that currently we seem to be missing a bit more frequently in my area is previous cesarean section at full dilatation. Now, as you know, cesarean section rates are on the rise, almost exponentially, it feels like. And a lot of those will be emergency cesarean sections, and a fraction of those will be cesarean sections at the end of labour. And that has its own pathology that increases the risk of preterm birth. And I will touch on that a little bit later. But these women, we need to be keeping a close eye on these women. So who is affected by preterm birth? I mean, up to 8% of the population, we know that. But actually, if you're a Black or Asian woman, you are at a higher chance of having adverse outcomes, and that includes preterm birth. So when we look at our national statistics, it's sort of sitting around 8.1 according to the last National Office of National Statistics in terms of the preterm birth rate. It's slightly higher, actually, for Black and Asian women, slightly lower for your white women. So actually, you've got these disparities as well in healthcare that can increase women's chances. You've also got socioeconomic factors which can play a part in preterm birth: poverty, housing, food insecurity, poor mental health, migration barriers. There's lots of different ways in which actually women can be affected. And one of the statistics that almost floored me when I was looking into it was today when I looked at Bliss Charity, which is a great charity for providing information and support for parents who have babies in the neonatal unit, was that actually one of the studies they did found that Black mothers, babies born to Black mothers were 81% more likely to die in neonatal care. That is like, it blew my mind. It terrified me, and being a black woman as well, it was something that just kind of really shook me to my core. So yeah, so lots of work to be doing in breaking down those barriers. So, with that being said, I really want to share with you guys a story um, that does have some sadness, but also has some joy, and it also reflects the importance of the work that we do. So, this is Joy. Joy came to us pregnant a couple of years ago, and I say to us as into my trust. She was pregnant with her first babies. She found out it was twins at an early scan. Black African lady. She had a history of they actually identified fibroids in um, her early pregnancy scan. So that's another thing, not uncommon to identify fibroids, especially with the ethnic group of Black African ladies. You're more likely to see it. So she presented 3 times in the early part of her pregnancy with abdominal pain. Again, not uncommon when you have fibroids, depending on the size and location. This can be sort of an instigator of abdominal pain more frequently. So she came in 3 times for abdominal pain. She was checked. She was told that everything was fine and sent on her way. She came back again around 24 weeks and 2 days with the same abdominal pain. And actually, at this point, when she was checked, they did a swab test. They took a swab from her cervix to look for certain proteins that are associated with the higher risk of preterm birth. And this test is called the actin partus swab test. And that came back positive to say that she was at high risk of having a preterm birth. So with that, those findings, we transferred her to a hospital that had a level 3 neonatal unit, which is a neonatal unit that specializes in very sick or very, very premature babies. So we wanted her to be in the right place for her babies, because actually we know that this helps to improve outcomes, reduce the risk of mortality and morbidity for those babies, reduces the risk of brain bleeds, and is overall is associated with better outcomes. So we wanted her, first of all, in the right place. While she was over there, she was given steroid injections to try and help those babies' lungs mature, to increase, again, the rate of survival, increase lung maturation, reduce the risk of brain bleeds and gut problems as well for her babies. So what happened next? Joy gave birth to her babies 4 days later while she was in the neonatal unit, 24 weeks and 6 days. And this is a very premature gestation. Baby Abel and Felix were born, but very sadly, Felix passed away within a week of birth due to infection and complications of prematurity. And I think, if I recall the statistics, so I think it's 4 out of 10 babies actually no, it's a bit higher than that. So at 22 weeks, you've got sort of 3 out of 10 babies surviving, with 1 in 3 of those having significant risk of disability. So as the weeks go by, that increases. So I think it's about sort of 4 to 5 of babies born at this gestation will survive, and there is still a higher rate of disability, lifelong disability associated with that. But baby Abel was born weighing 680 grams, and he spent 115 days in a neonatal unit between the level 3 unit and our level 2 neonatal unit, before being just discharged home at a corrected gestational age of 41 weeks and 4 days, weighing 3.3 kilos. So that was her journey through prematurity. And she, when I had the opportunity to speak to Joy after she'd had her babies, and when Abel came back to our neonatal unit to continue the care at the local hospital. So, she talked me through some of the challenges she had faced. And she, again, all the things that we hear in the reports, and there were certain points in her journey that she felt she wasn't listened to appropriately, that she felt that things could have been done differently. She didn't feel like she had enough knowledge and to be able to speak up for herself and advocate appropriately for herself and her babies. So she, surprised to us all, including herself, she was pregnant a year later. And she made direct contact with me. So this is one of the beauties of my job, when I get the opportunity to do it how I'd like to do it without the restraints of time, is that I get to build relationships with these families and actually give them the right tools and resources, where to go when they're coming into new pregnancies. So she reached out directly to me on my work contact number, telling me, "Oh my goodness, I'm pregnant. I'm totally freaking out about this. I don't know how we're going to do this." And I was like, "Right, we're here. We've got this. We're going to go for it. We're going to go for it together." She was referred early to our preterm team. She was seen early in our clinic around 12 weeks and very consistently throughout her pregnancy. In the early part of her pregnancy, we offered her cervical cyclage, because actually, if you've had a preterm birth around 24 weeks, you've had, adverse outcome where you sadly lost one of your babies. The options that we have for subsequent pregnancies will include the option of cervical length monitoring, where we scan your cervix regularly to check that it's staying closed and long and no signs of shortening or opening. Or we can offer you a cervical cyclage, which is a stitch procedure, which some people might have heard of, where they tie the cervix shut to give it stability and to keep it closed. Those options were both appropriate options for Joy because, again, as I've mentioned, because it was a twin pregnancy, it's a possibility that actually it was the association of having an overstretched womb with growing two babies might have been the trigger for the preterm labour. It could have also been a weakness in the cervix, but difficult to differentiate what was the cause of this. So the choice was hers, and we were happy to support her with both options. And we offered her progesterone pessary as well, which is a hormone pessary that goes into the vagina or into the back passage to just calm the womb down, try and reduce that risk of preterm labour. She opted for cervical length scanning to check her cervix regularly. So we do this between 16 and 24 weeks. And her cervix was stable throughout, which was very reassuring for us. And that kind of helped us to think, well, maybe actually that preterm birth was associated more to do with the fact that it was multiple pregnancy. But one thing I wanted to highlight to you all is that actually, aside from her 10 routine preterm clinic appointments that she had sort of between that 12 weeks and when she had her baby around 38 weeks, she had 22 triage attendances, triage and our day assessment unit as well, between 18 and 37 weeks. 10 of those were reduced fetal movements, 6 of those were for abdominal pain, 3 of those were for hypertension, and three of those were for scan reviews. So she had to, when you have frequent reduced fetal movements, you get put on a more frequent scan pathway. So she was having lots and lots of scans above the kind of initial care pathway that we had set out for her. So lovely little baby Elliot was born at 38 weeks and 3 days, weighing 3.1 kilos. I was privileged to be there at the cesarean birth. And it was just lovely to kind of get to that point with her, having been right at the start with her. It was a journey for us to get there. And the babies, both her boys are doing exceptionally well. They're almost the same size now because Elliot's just sort of shot up and Abel's, doing really well, very lively little one. And so that's Joy's story. So what I wanted to do is just have some reflections from this case. The impact of preterm loss or previous loss and preterm birth often affect subsequent pregnancies. You're going to see heightened anxiety. Women are going to go through a range of emotions throughout their pregnancy. There's guilt for, being in a new pregnancy. There's happiness, there's fear, there's anxiety. A lot of the time, there's mistrust of healthcare professionals. We do our best, but we don't always get it right. We may not necessarily have great follow-ups and communications. That's a real challenge for right now, at least in my unit. I don't know about if you guys are all perfect in yours, but administrative errors because they're cutting the staffing in our admin teams. Women are not necessarily getting appointments in time. Women can't get through on the phones. All of these kind of challenges. But there's also mistrust of their bodies as well when they give birth early. And you hear terms like cervical incompetence, which I hate. But weakness in the cervix. Women feel like their bodies have let them down. So we are, as a preterm midwife, and I work with, and I know a lot of preterm midwives up and down the country are doing a lot of work to try and, hold these women and be like, right, do you know what? This happened, but, this time round, we can do much more to support you. We'll be more vigilant. Your body can do it. So there's a lot of cheerleading going on. There's a lot of TLC to try and ensure women have the best outcomes and have a point of contact as well when they're having a wobble. And that's a lot of my job is, just catching women when they're having a wobble. But our work goes beyond the clinical care and is often restorative when we get it right. Frequent attendances, as you can see, there was sort of for this one patient, well, let's look at a routine antenatal care pathway. You probably get 10 midwife appointments, maybe an obstetric appointment just to kind of, go through some of your risk factors if there are any. That may be sort of 12, let's say. Well, actually, when women have complex histories like this, it can be really resource intensive. So she had more than 30 care episodes with us. This is why getting it right is so important. And I just wanted to highlight as well, fibroid pain is real, and often the pain of a Black woman is dismissed more frequently than for any other ethnic group. And Joy gave me permission to share these photos. These were the fibroids that were imaged at her cesarean section. So I just implore all my colleagues out there, student midwives, whoever you are, whatever hat you wear, when women have fibroids and they're coming in with abdominal pain, we don't know what is going on in their bodies, what they're going through, the size of these fibroids, the impact of these fibroids, whether they might be small but degenerating and causing a significant amount of pain. So this is just some food for thought about the internal struggle of a woman that we don't always get to see. And actually, this is why I sort of was like, please, can I share this? Because people need to understand that you came in for abdominal pain more than 10 times. This is why. And we don't always get that for other women coming in with abdominal pain, the reasons why they're coming in. So what can midwives do? I've talked about all these things, what's not so great, where the areas of improvement need to be. But I break it down like this: prediction, prevention, and perinatal optimization. Well, I'm not going to take credit for that. That's actually like, Saving Babies' Lives, British Association of Perinatal Medicine. But when I relate it back to what midwives can do, what I perceive is that actually prediction, our role as midwives is to identify those risk factors. So our booking midwives are best placed to, when they're meeting those women for the first time, to really dig deep into that. When we're asking those questions, if we've got a woman who doesn't speak English, we need to be getting our translators involved so that we can really break down some of those barriers, really understand what those risks are. And if we're unsure, we need to be referring them to specialist services in relation to the area that we think they might need some extra support in. So sometimes women will be referred to my clinic. I don't think it's an appropriate referral because she's had a preterm birth by cesarean section for growth problems. That we don't think that's a cervix problem, but actually because she's had that baby maybe in a different country, or there's a language barrier, I will still invite those women to our preterm clinics, and I will still offer them internal scans to check their cervix just to make sure we haven't missed anything, because those are the women who will rock up in labour with those preterm babies. So risk assessment at every appointment, because risk is dynamic, as we all know. It changes, it varies. That 1 minute they're low risk and suddenly 3 risk factors have popped up. They need to be on blood thinners. They need to be having, blood pressure monitoring, all of these kind of things. So it's about consistent risk assessment at every contact, checking that they understand what are the risk factors for preterm birth. Do they know, that what contractions or waves of pain are coming and going, discharge that's changed, mucousy discharge, suddenly pinkish discharge, any weird funky discharge, I'm like, they should be coming in to be seeing us. Acting early on symptom identification, escalate promptly. If you're not sure as a midwife in the booking clinic, reach out to your preterm birth team. Hopefully there's more and more midwives popping up for preterm birth services up and down the country, but reach out to them. They're more than happy to connect with you. If you don't understand some risk, please reach out. We love teaching, as you can see, we love talking. So we'll be happy to explain some of these things to you if you don't understand it. Reach out to your obstetric colleagues as well, to see, is this a risk factor that needs to be escalated? Document and communicate. Make sure your documentation, shows that you have identified those risks. When we talk about prevention, we're talking about reducing the risk for women. So making sure that actually we're getting them into preterm clinics in a timely manner so that we can assess them, we can monitor their cervix if that's appropriate, or offer them the right treatment. Promote smoking cessation, because this is the single most important thing that women can do to reduce their risk of preterm birth. Most of the other things are just factors that are out of their control, but if they can stop smoking, that is one of the things that can significantly reduce their risk. Recognize and treat infections. So those urinalysis that we're doing, a screening for infection, is it burn or sting when they pee? Are they is their discharge suddenly smelly? All of these kind of risk assessments and recognition of symptoms, teaching them about that as well, so they know that actually, oh no, this isn't normal. My midwife told me to check this. Ensure timely referral, as I've said. Encourage attendance and awareness. This can be quite challenging. that, if women are not attending, then we can't even identify them and we can't even support them. So just driving that home about the importance, using our national bundle. So we've got Saving Babies' Lives, which sort of gives us nice sort of clear ways of supporting these women when they're coming in. And then perinatal optimization. So this is the preparation, the third P that I talk about for encouraging timely preparation for a preterm birth when we don't think that we can stop it. So that's our steroid injections for the mum to try and help improve optimization for the babies. We've got our magnesium sulfate, which is horrid medication. If you've ever seen a woman having magnesium or have had it yourself, it does feel like you're being set aside on fire from the inside out. That is how women have described it. They feel an impending sense of doom. They are red, flustered and hot. So tell them that that's what's going to happen so that they know that this is a normal thing with this medication. Get the fans going. Soak a pad in cold water and have it ready for the forehead. Give the partners something to do because they're usually looking like deer in a headlight in the corner of the room, aren't they? So, get them to hold a fan or a folder or something they can use to fan so that when they see their partner going through what looks pretty horrific, they know that it's coming, they have a job to do, and they're there to support their partners. So, and your antibiotics to protect those babies from infection, which is much higher when their immune systems are lower because they're preterm and early. Communicate early with your neonatal team. They're a great source of support for those women because they'll prepare the women for what to expect in the neonatal unit. They'll prepare them about the tubes that baby's going to have, getting breast milk early for baby, what it's going to look like when there's lots of people in the room all there to support their baby, to give their baby the best start. And they will help you with that as midwives. And then optimizing care at birth. So as much as we can do delayed cord clamping, which is vital for these early babies to help stabilize their blood pressure, reduce the risk of anemia and the need for transfusion for these babies, and just give them the best start. And, working as part of that multidisciplinary team. So, you're from the top down, your coordinators supporting you when you've got women coming in, your obstetricians are supporting you, your neonatal team are supporting you. It's a team effort, team preterm. So and then just, ensure that you know for yourself what the risk factors are for preterm birth so that you can act quickly if you encounter any of these things. And just remember some of these barriers because maybe we can overcome some of those. So late booking, we know that sometimes getting them in early is a challenge, whether they understand the way healthcare in the UK works. Missed appointments, do they understand the importance of that? Health literacy, do they know what maternity care is supposed to look like? Do they know about what normal blood pressures and normal urine samples are supposed to look like? Symptom recognition, digital exclusion. These are challenges that we're facing currently at the moment, and language barriers. We're seeing more and more translation services available, but that's something that we need to be using more of. Fear of discrimination or being dismissed. A lot of women do feel that at the moment. And lack of continuity. They're seeing different antenatal midwives at every appointment. It gets tiring trying to tell your story every time to a new face. So, prediction tools, all of these things I'm saying only work if women can access and engage in care and can trust us as healthcare professionals to give them the best care. So this is where I implore my service managers, my leaders, my higher ups, all of the big guns. This is where you can help us as midwives to give the best care. Community champions. So we want good links with our community. So our MNVPs, we want to be able to have a hub where there's someone who's an expert in prematurity, be it the obstetrician or the preterm midwife, or someone who's a champion for preterm birth that can sort of build those networks in the community. Use social media. Let's set up campaigns in social media to be able to get those women's stories out there. We should be empowering women with scripts. I feel like this is a huge thing and hopefully not too hard a thing to do. Scripts for women who need to be contacting our triage to go, I'm concerned about my baby because XYZ. This pain feels like this. The bleeding looks like this. Do we have a means for them to send us pictures of? I know as midwives we love a good picture, don't we? Because it helps us to kind of visualize what's going on. The blood loss, picture of the discharge, picture of the mucus, picture of it's going to help. Visual things help. So let's empower women to be able to share that with us so that we can then give them the best care. We want our leaders to help us, empower us from within to be able to provide the best care. We should be getting patient stories out there. This is how we get engagement from our harder to reach communities. Find champions in those communities. Get the patients to tell their stories in their native language. Let's share it. Let's get it translated. Let's do it the other way around. Rather than everything being in English, let's get it in other languages and translate it into English. Short videos, mini interviews, these are the things that are going to help us with engaging our community. That's why TikTok is on fire. That's why Instagram is really popular. People want to hear people's stories. We should be doing that on a level in the safety of in an environment where we can teach and empower women. So yeah, for women, talked about what our leaders can do. Now for women, act early, know the signs of when to attend, those regular contractions or waves of pain coming and going. You're noticing a pattern in your tummy or in your back. If has your discharge suddenly increased? Is there vaginal bleeding? Anything like that? How do you contact? Who do you contact? Are you still in the early stages? Is it your early pregnancy unit? Is it your maternity triage? We should be empowering them, and we should be encouraging them to know that as well. Have a contact number saved on your phone, so you're not kind of back and forth about, oh, I'm freaking out now, I'm worried about this. When you're worried about something, the last thing you want to be doing is trying to scroll somewhere to find the contact details. Keep a record of your symptoms and concerns, and bring someone with you where possible. I know it's not always possible. In an ideal world, bring someone with you who can relay some of the information you've heard back to you as well. And if you are concerned, seek a second opinion. Ask your community midwife. If you don't feel bold enough to say that in your appointment, ask your community midwife to make another referral to you. We've seen recently with Martha's Rule coming into more and more trusts as well. This is something that women need to be aware of. And trust your instinct, women. You know your body. You know when something's not right. And even if you've had a sort of a traumatic previous experience, there are things that you can do to help you identify when something's not quite right. And so I just want to finish off with this. So I'll be done soon in a few more minutes, Sue. Cesarean section at full dilatation. I want to just talk a bit about this because I'm seeing a rise in cesarean section rates nationally, and also I think there's not a lot of awareness about this risk factor. So when you have a cesarean section at the end of labour, your cervix has become part of the lower segment of the uterus. And what do we call a cesarean section that we do? And it's a lower segment cesarean section. So actually, there's a possibility that where they're making that cut to get baby out is going to be encroaching onto the cervical tissue, so the cervical canal. But you'll never know that at the time because it's all part of the lower segment of the uterus. So this is why we want to see those women in subsequent pregnancies, because actually when all the anatomy goes back to normal, in subsequent pregnancies, what you find is you're able to see if those women are going to be at increased risk, if there is damage to the cervix, if there is a shortening of the cervix due to some kind of trauma during that cesarean section, if there's what we call a niche, or where there's sort of a little opening where there's been a scar in the cervix. We can see those during a cervical length scan, and we usually offer that around 18 to 22 weeks in a subsequent pregnancy. So women, if you've had a cesarean section, mention this. How far along did you get? Were you pushing? Did they try to get baby out with a forceps or a suction cup? Use language like that to help your midwife know what the risk is. And midwives, simplify the language that we're using. When I talk about language barriers, some of the language barriers is the terminology that we use. It's not even foreign languages or it's just, did you have a cesarean at fully dilated? Sometimes women don't understand that. And actually it's like, oh, when did you have your cesarean section? Was it 10 centimeters? I don't know. Were you pushing? Could they see baby's head? All of these questions can help for midwives to ascertain and identify some of those risks. So it's really about probing. Be a detective, midwives. We're so good at being detectives. So think about this when you're thinking about preterm risk. Be a detective. Go all in to make sure that we're doing the best for these women. So helpful resources. I've sent you a nice list of lovely resources that are available to support women and their families through a journey with previous preterm birth or previous loss. And as Sue's mentioned, I've also written this book, which I've basically used some of the stories that I've heard in my time as a preterm birth midwife. I've anonymized these stories, and I've sort of, a bit poetic license, I've put together a compilation of 7 stories, and then I've used those stories to provide a resource and a tool to go, women, this is what you need to ask if you face a similar situation. It doesn't have to be identical, but if you're attending maternity triage for assessment, ask questions about your cervix. Does it look normal? Do I need to take any medication? Is there something I can be doing to improve the outcomes for my pregnancy? Did you see a cause for preterm labor, or for this bleeding, or for this pain that I'm having? It gives women prompts on how to ask questions, how to confidently and boldly engage with their healthcare professionals, because that's when we see the best outcomes, when we have women who are inquisitive and curious and asking those questions, and when we have healthcare staff who are also inquisitive and curious and asking those questions, and spent spending time to actually get to know women and understand some of those risk factors as well. Tommy's is a fountain of all good things in relation to preterm birth. 5 times more report. If you haven't read any of that, I implore women, service users, women, healthcare professionals, midwives, nurses, and anyone and everyone, read about the women's experiences of Black and brown women accessing healthcare. What does it look like? And what does it feel like to be someone who's read those reports, who is Black or brown, accessing care and worried about how you're going to be perceived? So think about that when you're caring for women from global majority backgrounds. Anyone who's not non-English speaking, think about those barriers, those challenges to care. Sometimes they've accessed care in foreign countries and they're just happy that they can access care here, and they'll take the bare minimum and they'll put up with the bare minimum. That's not what we want for our women. Birth Rights is also their Bliss organisation. And yeah, you know, if anyone wants to purchase a copy of my book, there's got an ebook and it's a hard copy as well, all available on Amazon. So thank you all very much for listening to me waffle on for so long. I just want to say a big thank you to all midwives out there, because you do make a difference. And I know that it's been challenging over the last few weeks, years, months, the whole time. It's just ongoing. But you are making a difference to women, and please keep going. Please persevere. You know, the women that you've impacted know, and they will feel that forever. You are a part of so many women's journeys. You make a difference. Your assessments, your actions, your advocacy, it counts, and it can buy those babies weeks, extra weeks in the womb. Thank you very much.
Fabulous. Fabulous. You see, I want to do a big applause, Dede. So that was really good. And I think you really illustrate. I mean, I've done little notes on my scribbly bit of paper, because a lot of what you were talking about, this could be applied to any part of midwifery. And I think the interesting bit, and the thing I really love, is the advocacy that you're promoting, of getting women and educating women to know how to navigate the system, how to speak to us, which in a way, well, and to other people within the service. And it is quite, for any of you who've had to go into a hospital, it's a very alien place if you're unwell or if you're needing care of some sort. And I think we forget that when we're in it, because we're used to it, and we're used to the things that I was really interested when you were talking about language, and the language we use, and trying to make it very simple. And I think that's fundamental to being able to communicate with women and their families, and communicating with the baby, because that's another language altogether. And I think that was really interesting. I mean, I like the bit, the way you're talking about the sort of, and I think people have written about this before, about the language we use that implies that women's body have failed.
Yes. It riles me up. It's one of my pet peeves in my job. Because it's not, it's just an underlying pathology that we haven't found that we could potentially make a difference with for those women. I don't know how we move forward from that, really.
Well, I think we talk about it, which is what you're doing brilliantly today. And I think any of you who are watching, and I know probably some people are putting questions in, it's a bit slow, my computer, but if you have a question for Dede, do throw it in. But I think being able to share, I mean, I would, my first thing would be to go into work tomorrow and say, well, listen, guess what I heard last night about this wonderful woman called Dede, who's really passionate about preterm care, and she was talking about language. And isn't it interesting, the language, some of the language we use? Because I think when we start talking about it, you start thinking about it in a different way.
Yeah. And we had an incident like this, which is why I just wanted to talk about the cesarean section at the end of labour. We have a lady who's had a preterm birth, like, you know, it happens all the time. But actually, when we've audited the notes, oh, she's had a cesarean section at the end of labour. That's not been identified. And when the doctors was talking to her, she very clearly knew that she'd had a cesarean section at the end of labour. But I guess maybe it hadn't translated the same way when she had that conversation at the booking about, oh, yeah, like, you know, were you pushing? Were you not? Like, what, did you have a baby? You know, was it fully dilated? Sometimes it's the language that we use. And also in screening, like I've had that even in a conversation I was having with patients this week, where I was like, oh, have you had your anomaly scan? And she said, yes, she has. And I said, oh, okay, then. And then I was only when we went a little bit further, I sort of thought, actually, I can't see it anywhere on any of the systems. And I said, so when is your 20-week scan? And she said, oh, it's next week. So I was like, oh, in the same 10 minutes, I was told that she had had it. But actually, when I changed the language I was using, it became clearer to the women what I was talking about. Who knows what an anomaly scan is? And I think that's some of the things I have a glossary in the book where I sort of try and break down some of those terms for women that they're going to hear in, you know, even just things like early pregnancy unit or day assessment unit, or, you know, what does that mean? And that's different in different hospitals and different trusts, you know. So it's like, oh, well, where do I go? I'm supposed to go to an assessment unit. Well, sometimes the triage is the assessment unit. So where is this poor woman going? But yeah, language is a very interesting thing when we look at people's perceptions and understanding.
Yeah, and hospitals being a bit different, as you identified. And I thought that your issue about, I mean, that the fibroids was a big thing. My goodness. Well, they were big things themselves, but the issue
Yes, they
of
were.
pain and the experience of Black women and the kind of belief that Black women don't feel pain in the same way.
Yes, there's that stereotype that does
Which
exist
is
as well.
bizarre, whether that's from that old work that was done donkeys years ago, probably at the turn of the century, where that was kind of a belief. What I mean, how can we stop that perpetuation?
I think we need to listen to women more. I mean, you know, you do get stereotypes as well. I think when at the trust board when I spoke this morning, one of the ladies said, "Oh, like, I've heard the term about Asian women being princesses," and I'm like, well, that's you. Then when you go that way in your thinking, you miss things. So when you think that actually Black women's coping well, or is really vocal actually, so she's not coping at all. Actually, you know, have you had a conversation? Have you reviewed her birth plan? Have you talked about these things beforehand? You know, do you know how this woman expresses her pain? Or, you know, the lady that's quietly there. Oh, she doesn't look like she's in pain and she's 9 centimeters dilated and we've not been able to get any optimization in, all that kind of thing. Like, it's just about asking the right questions, putting those kind of preconceived notions aside and looking at the person that's in front of you and finding a way to communicate effectively with that person in front of you so that you can provide them with the right support.
And continuity of care. You have
That's where it all
illustrated
starts.
the value of it so well, especially with your first case study of looking after and that lady so beautifully, and her phoning you on your phone.
Yeah.
Please first to know. That was lovely. And that isn't that a call the midwife moment?
Yeah, yeah. And that is what I desire for all women who have this kind of
Yeah.
background in history, is that they have someone that they can go to early, because all of that before booking, if they've known for 2, 3, 4 weeks, imagine the amount of anxiety and uncertainty that they're already trying to process.
Absolutely.
And then they book, and then they wait a further several weeks before they see a specialist team. You know, there is definitely scope for us to do some work with those women, even if it's check-ins, even if it's sort of early scans, just to go, right, everything's fine, you're fine, baby's fine. Even if it's just kind of setting up the medication regime, right, so you're going to start your progesterone, you're going to maybe start your aspirin at this point. Like, having a care plan in place reassures those women remarkably, to the point that it eases a lot of that anxiety from early. When they know what they're to expect from the care, that anxiety eases.
I mean, I have to say, I'm banging on about continuity of care because I was thinking the other thing that stunned me, because when the way it's laid out of the money, and I'm sure that was of interest to other people you were talking to today, because obviously money is important. And I can't help thinking, if you could just stretch a pregnancy a bit longer, you'd save a huge amount of money.
Huge, a huge
And
amount.
it's kind of logical, isn't it, really?
Yeah.
And hopefully your words of wisdom this morning will have just hit everybody hugely. Fantastic,
I hope so.
fantastic. And I did have a query. Now we had again, it was the black babies, 80%. It's 80% more likely.
I had to run that by colleagues. I was like, can you just read this, please? Because I can't believe that this is a thing. And I don't know whether it was an isolated study. I definitely have to look a bit more into it because, so I feel like I have to do a bit more digging, but that came from Bliss. So obviously a reputable charity.
Yeah, absolutely.
They've done, it was a research that was done. Shocking, completely
shocking.
blew my mind. Blew my
Shocking.
mind, and just made me sort of quake in my boots a bit for family and friends that I know who are black.
I think it should rock us all. Actually, it's fantastic.
I hope so. Yeah,
really important. Now I've got some comments through. You've been quite quiet today, audience, but I'm glad you're there. And I've got comments from Diane Garland. Hi, Diane. Welcome back. Who says, interesting session and lived stories really gave a great way to present what you've done. And then Melanie says, thank you so much for sharing experience. Thank you, Melanie. And Kehinde Olefa says, this is a very brilliant and informative session. Not just brilliant,
thank
but
you,
very
Candy.
Thank you.
Thank you. Yeah, so I'm going to make an assumption there that you are one of my Nigerian sisters there, because Kehinde is a that's one of my cousin's names actually.
Did
She was
I
a twin.
nearly
She's
get
a twin,
the pronunciation right?
Yeah, you did well. You did well, Kehinde.
I'm trying. I'm just trying to think of any. So we've got the changing language and simplifying language. We've got really illustrating continuity of care and how it could save money and also help women understand. And actually that the advocacy is such an important area. And thank you so much for sharing that. And is there anything else you could give us another tip about advocacy? How do you cope with a woman who said, when you say, what would you like? And she'll say, well, you do what you think's best. So, for example,
actually, you got me?
Yeah, sound just dropped a bit.
Yeah, so I think when a woman trusts you and you are working collaboratively, that I often get women will say, well, what do you think I should do? And I think we can look at the evidence together. We can go over that. It's still the woman's choice. You can, say this would be our recommendation as part of our team. This is what we offer and this is what we advise. What feels right to you? What is important to you? So, for example, in Joy's story, she didn't want to have a spinal anaesthetic to have the stitch procedure done, which is fair. Like she was like, actually, if I don't need to have that, I don't want to have that, and that's a discussion that we can have with women. So sometimes we'll be like, we really strongly advise you to have a cervical cerclage. Please have one. And the women, there's barriers to that because women they've had a bad experience with a spinal anaesthetic in the past. So then we do a bit of counselling around that. We talk about the options. We talk about what's available and how we can overcome some of that. We talk about if general anaesthetic is an option. Sometimes it's more risky and it's not preferred by the anaesthetist, but is this a personalised care to offer that as the alternative for this woman in front of me? Then that you can bring in your multidisciplinary team to have that discussion. So it's always about what is important to the woman, and what is clinically necessary. And when you put those two things together, then actually you and that woman trusts you and you gets to know you, then that's where you can see a difference in outcomes as well.
Fabulous. This has been a fabulous session, and thank you so much, Dede, because it really has
Pleasure.
A huge impact on what we do as midwives. And you've packed so much in this time. I think more than an hour. I always say this is the fastest hour in the week, and this really has flown by really quickly. So thank you so much for sharing your knowledge with us. And I'm going to say thanks to Dede. I'm going to say thank you to Angelo. Angelo's in the background, making sure this is all nicely recorded so you can re-look at it, because I suspect some of you want to look at those wee slides with all those the information so clearly, and so also the resources, because some of them will have to go on later because I got some of them, but not all of them. Sorry, Dede. This is my computer having problems, having a hiccup. And thank you also to Paul for looking after the live Facebook section. This is all going to be available on Facebook on Friday. Now, next week, we've got Molly O'Brien, who's going to continue a story of movement and the benefits in labour and birth. So that should be a lively session next week, same time, same place. And in the meantime, please take care of yourselves, and we'll look forward to seeing you next week. And thank you very much for being with us this evening. And thank you, Dede, again. Fabulous. Thank you.